quiero presentaros a os lo voy a presentar de forma virtual porque no les tendremos de una forma menos virtual viéndoles en la pantalla hasta la 1:30, ¿no? Pero sí quiero un poco daros un perfil sobre los 4 ponentes extranjeros que yo creo que hemos tenido la suerte de tener con nosotros hoy, a los que agradezco mucho, ya, aunque no me estén entendiendo ahora, a los que agradezco mucho que hayan participado en esta jornada, ¿no? En primer lugar, hablará el representante del Servicio de Israel, Shane Rafalowski, del Magen David Adom, que es el servicio único para todo Israel, ¿no? Shane Rafalowski es ya una persona muy veterana en estas lides. Él es el responsable de los procedimientos especiales y también de los proyectos europeos. Digamos que esta persona será seguramente de las personas que más proyectos europeos ha llevado con respecto al ámbito de la emergencia, ¿no? Viejo conocido nuestro, hemos participado con él en varios proyectos y él, bueno, pues nos va a hablar sobre cómo ha sido la experiencia, las actividades que ha hecho su servicio a lo largo de la pandemia. En segundo lugar, tendremos al representante francés, a Benoît Vivian. Benoît es el vicedirector del SAMI 75, que como sabéis, el SAMI 75 es el SAMI de París, ¿no? Él es un anestesista, trabaja en el Hospital Necker, que es donde está la sede del SAMI de París. Y bueno, ha sido un poco el que ha llevado todos los procedimientos especiales durante el COVID y el que hizo y el que planificó estos grandes traslados con el TGV. Él actuará en segundo lugar y él nos hablará en directo, ¿no? El israelí es un vídeo que nos ha grabado y el segundo ponente, el francés, actuará en directo. Después del profesor Vivien tendremos a Freddy Lipper. Bueno, el doctor Freddy Lipper, que yo creo que es una referencia para todos nosotros en muchos ámbitos, ¿no? Es el creador de la Global Alliance, de la resucitación, es una persona absolutamente referente en todo el campo de la resucitación en los últimos 20 años. Ha creado la Academia Europea de Resucitación, también la IMS Leadership Europea. Bueno, es digamos uno de nuestros referentes, seguramente de las personas que más ha publicado, tiene como 160 papers en revistas científicas, etcétera. Digamos que es una de las referencias y también es el responsable del servicio danés de emergencia, ¿no? Y él nos va a hablar fundamentalmente de cuál ha sido el trabajo, las líneas generales que ha tenido su servicio durante la pandemia en Dinamarca. Y por último tendremos a James Ward, es el director médico del Servicio de Emergencias de Escocia, ¿no? También una persona con referente en este mundo de la reanimación. De hecho, fue uno de los que creó, bueno, pues el procedimiento de trabajo en Escocia con respecto a la RCP y bueno, al que agradezco mucho que también nos vaya a contar cómo ha sido la experiencia del servicio escocés de emergencias durante la pandemia. Bueno, y vamos a dar paso ya al primer vídeo, lo tenéis en pantalla ya.
Dear colleague, dear friends, a pleasure being with you this afternoon. My name is Chaim Rafalowski. I'm the Disaster Management Coordinator of Magen David Adom in Israel. And before I start talking about Magen David Adom activities during COVID-19, great thanks to my friend, Dr. Vídeo for the invitation and the opportunity to be with you on this distinguished forum. I will talk today about the Israeli healthcare system, then about the current situation in Israel. You are all aware that we are in a good situation. Magen David Adom response to COVID-19 and some of our lessons observed. We have to start talking about the geography and demography of Israel. We are a very small country, only 9.3 million inhabitants in a territory of 220,000 square kilometers. You see how many times we would fit into other countries, everyone and the countries that you like. Geography and demography were extremely important in our success story in the combat of COVID-19. The other important aspect is the fact that in Israel, we all have a medical insurance. It's mandatory, it's by law. And the medical insurance and the primary healthcare providers, our HMOs, played a major role in our response to COVID-19. In the structure of the healthcare system, we have the Ministry of Health. And under the Ministry of Health, we have a special entity, a unique entity, which is called the Supreme Health Authority in emergencies. The Supreme Health Authority was created for war times. But the idea is that there is an entity directly under the Ministry of Health and managed by the Director General of the Ministry of Health, which brings together all the actors in the healthcare sector, either private, public, belonging to the municipalities or NGOs like Magen David Adom. So the questions, are you public or are you private, doesn't matter, because we are all working under the same umbrella as one unified healthcare system, a very important strength of the system. And I have to say that we activated a very old law about the outbreak of ultra contagious diseases that gave the Ministry of Health many powers during this pandemic. For example, since January, end of January 2020, healthcare providers could not travel abroad for a year in Israel without a special permit from the Director General of the Ministry of Health. As I said, we have 4 primary healthcare providers. They are called the HMOs, with presence all over the country and coverage of 100% of the population. We have 27 general hospitals. In the Israeli system, only general hospitals have an emergency department, so they will receive urgent cases. The private sector is only for elective surgery. They have hospitals, but those hospitals don't have emergency services. And the EMS, we have one national ambulance provider, EMS provider for the whole state of Israel. This is Magen David Adom, the Red Star of David. You can see that Israel had 3 major waves of illness due to COVID-19. One was in February, March 2020. The other one was around August and September of 2020 because of early relaxation of measures, countermeasures to COVID-19 and people not observing the rules, social distancing, masks, and so on. And the other one, which was very, very challenging because it was the toughest one, and you can see the graph there around January 2021. And I would like to remind you that Israel started vaccinating in mid-December 2020, which means that we were vaccinating while we were having the worst outbreak of illness during the pandemic, a great challenge to our healthcare system. And here you can see how we went down from almost 4,000 cases and 4,000 new confirmed cases on a daily basis in March was already a major decrease from the figures that we had in February, which were around 8,000 new cases on a daily basis, which was a reason of great worry in our healthcare and the management of the system in Israel. And nowadays we are around 12 new cases on a daily basis. Magen David Adom, the Red Star of David, is a very interesting organization because we are the National Blood Service. We are the largest trainers in pre-hospital care. We are the national public ambulance provider for the whole country. We are the National Society, part of the international movement of the Red Cross and Red Crescent, and as any other Red Cross society, we are auxiliary to our public authorities during emergencies. We are a rather small organization with 2,500 paid staff, but proudly I would say that we are 22,000 volunteers. We all started our careers as volunteers in Magen David Adom, myself, my Director General, our Head of Operations, and we have 3,500 first responders, dedicated people who are on motorcycles or in their cars, providing a community response to emergencies. This is really our muscle that allows us to provide, to grow up in the operation very fast, and this is what was needed during COVID-19. If I go to May 7th, the end of the first wave, and back then we did not think that we will have a second and a third one, just to give you an idea. Magen David Adom started very early sampling in the pre-hospital setting. One of the first questions asked in Israel was, who will take the samples from people? Are we going to use highly trained nurses and doctors to do that? And the answer was no, we need them in other places, basically treating patients in the out of the hospital in the home care provided by our HMOs or at the hospitals. And at the same time, we needed people who are mobile, used of working in the out of the hospital setting, and used to work in PPE. And this is something that paramedics and EMTs know how to do. This is our daily job. So we started going home, door to door, taking samples. Very fast, we realized that this is not possible, it's not feasible. So we shifted to drive-through, what we call the drive and test facilities. And we did a major campaign testing the nursing homes, the long-term care facilities in Israel, which were the source of the high mortality during the first wave of COVID. Of course, we also treated and transported patients who were confirmed as positive. And we took convalescent plasma, that's plasma of recovering patients that is used in Israel to treat critically ill patients. I would like to draw your attention that Magen David Adom has its own emergency call centers. We don't have a 112 Israel system in Israel. And on an annual basis, we do around 2 million calls a year. This is our normal yearly work. And here in 3 months, we did the work of 1 year. The worst day, you can see, if normally we deal with 6,000 calls a day, on the peak, March 31st, we did almost 90,000 calls in 1 day. An interesting phenomena, all the information was available to the public on the websites of the Ministry of Health, on the website of Magen David Adom, and still people would be calling us to ask questions. People who are worried, who are anxious, need a human voice to talk to them. This, I will come back to this because this was one of our greatest lessons observed during the pandemic. This is a video prepared to thank our people for their tireless work. These are the sampling, the drive-through centers. This is our National Operations Center. Our volunteers supporting, answering the calls. This is the sampling. And transport on to the for their tireless work. These are the sampling, the drive-through centers. This is our National Operations Center. Our volunteers supporting, answering the calls. This is the sampling. Just a few images. You can see here one of our first EMTs that was sick with COVID, and when he recovered, one of the first things he did, and this is the director of our blood services, and you can see this is very early in the pandemic when masks were not mandatory. He came to give plasma for other patients. One of the issues that we had is that young people in Israel don't shave, and you cannot wear a fit mask to your face if you have a beard. So we had to ask them to shave. And what this paramedic put on his Facebook account was, "I'm a paramedic, Corona, you not break me. 21 years I did not shave, but being a paramedic is making sacrifices." So he put his photo after shaving, and this is the wall of the old city of Jerusalem, and you can see how the municipality of Jerusalem lighted the wall saying, "Jerusalem salutes Magen David Adom." We had to deal with some special groups. We celebrated Ramadan twice during Corona, and we had to put testing sites during nighttime because people that are fasting during day will not come to be tested, and of course to publish some public guidance information about how to still be safe during Ramadan. Ramadan is not just about fasting, it's also about iftar, the dinner after fasting, where it's a family gathering. So we had to talk about how to do family gatherings in a safe manner. These are images. This is a car, an ambulance that was fitted to go to the Bedouin communities in Negev. They live apart one from the other. These are ultra-religious Jewish communities that many of them don't have cars, so we either transfer them by ambulances to the testing sites, or we put this caravan in the middle of the neighborhood, so people will be able to come and be tested, walk in, and this is an image that the team did not know that it's being taken. This is a team in Beersheba, an ultra-religious Jew, an ultra-religious Muslim, and every morning when they work together, they ask for 10 minutes break, so they pray. For those of you who are not familiar, the Jew is praying to Jerusalem. In Beersheba, it's to the north, and the Muslim to Mecca, which is to the south. This is why they are back to back, and when they are asked, what they were asking was that they were praying to God that the pandemic will be over. Unfortunately, it did not happen. You can see that most of our population that can be vaccinated is already vaccinated. We have around 1 million people that don't want to be vaccinated. I'm going to talk about the vaccine hesitancy in a second. And you see how we started with people that are older than 60 years old, and there more than 95% of the population are already vaccinated. Healthcare providers, significant hesitancy, and today everyone can be vaccinated in Israel, and we are vaccinating the 12 to 15 years old. Very slow rate of vaccination in that group. This is a very interesting study that was done to show the efficiency of the vaccines, and you can see that really the Pfizer BioNTech vaccine provides the results that they promise of 95% of preventing considerable or severe disease and death. And then here you can see in the graphs how the number of cases decreased, especially in the elderly population and the 60 and older. And here you can see how the number of deaths drop dramatically following the vaccination. We, as I already mentioned, we have a strong primary healthcare system. Of course, we are Israeli, so we have a good crisis management structure. The geographical dimension and demography were extremely important in our capacity to vaccinate so many people in such a short time. Just to give an idea, Israel is organized in a way that we have one central storage for the vaccines, and from there it's distributed all over the country. And in the worst case scenario, in 5 hours in normal driving, you will be everywhere in the country. So that's not an issue. And in Israel, we are flexible. But we had an important vaccine hesitation. Of course, the conspiracy theories were in place. People will tell you that the chip will be implanted, and I'm still waiting for the one case where they found the chip, but it's there. People who don't trust the authorities as a baseline, of course, found it as another reason not to trust the authorities, feeling that they are forced to get the vaccine and they are pushed to do something against their own will. People will argue that the vaccine is not safe. I hope we managed to convince them. Something which caught a lot of attention in Israel is this idea that the vaccine might cause fertility issues that had no evidence whatsoever. The problem is that when it comes to fertility issues, we can explain that there is no logic path to that, but since especially when we started, it was very early. We did not have, and we still don't have the science, the data to show statistically that the vaccine is safe when it comes to fertility, even though we know that this is doesn't make sense, especially with pregnant women, and because of the British variant. Sorry, I should say I think it's the Alpha variant, as we should say now. We had to change the vaccination policy from following Pfizer guidelines that recommended not to vaccinate to asking women in second and third trimester to vaccinate urgently, because we had severe cases of women who even died, pregnant women who got the British variant and died. So the policy changed very rapidly, and of course it did create a lot of fuss and mistrust. People would tell you that they are young, and for young people it's not serious, and they will tell you that if they did not get the disease so far, they should wait, which of course is stupid. Here we have an issue of personal confidence. And it's amazing because you could give a lecture of an hour to people, and after an hour lecture, they will look at you and say, okay, did you get the vaccine? Yes. Your family, are they vaccinated? Yes. Okay, so I trust you. You're a serious guy. I will take the vaccine. So my personal feeling is that it was more about trust than anything else or science. What are the lessons observed that I would like to present you? First of all is that we had to take care of our own personnel. Small things like there is a quarantine out there. How am I going to get my food? Or, okay, I might at the beginning, of course, every contact with a patient when you're not sure if you were well protected, you had to go under quarantine, and people would come and say, I'm living with my elderly parents, sorry. I'm afraid to come back when I have to quarantine. Solving all those issues became a critical thing in the trust of our people. We had to explain, people in the EMS, at least in Israel, are used to guidelines and protocols, but the protocols were changing. Sometimes they were changing every day. So we had to explain to people that we are changing protocols because we are learning, because this is something new. And since it's new, we will bring the best evidence that we have, but we will make changes. They got it very well, but it created at the beginning a lot of uneasiness because, okay, if we don't know where are we taking these decisions? We had to make changes along the way in the level of PPE that we are using, in the disinfection. At the beginning, after each patient, we were bleaching our ambulances with 3,000 ppm of bleach, and it was destroying the equipment. And we realized that it's not necessary, that we can have safe ambulances without destroying the ambulances. So again, something that we learned, we changed, and we had to communicate, and communication was critical. Treatment protocols changed like 3 or 4 times during COVID pandemic. Of course, the way we train people changed, and we are still struggling with those changes in training. One of the important things that was pushed through throughout the pandemic was the idea that EMS sees a lot of patients, and many of them don't have to get to the hospital, and we are pushing very hard on telemedicine. So really, patients who don't have to be transferred to a hospital will stay at home and receive some primary care, and we will be in better contact with their primary healthcare providers. So they will receive the answer they need, not necessarily through an emergency department. I would like to point out silent hypoxia, because silent hypoxia was a shock to all of us. All our lives we were trained, look at the patient. If the patient is smiling, don't trust the pulse oximeter. And then suddenly we learned that we should trust the pulse oximeter, and the patient which is smiling might crash in 3-4 minutes and die in front of you. I think this is something that we should look into it and see maybe we have other blind spots in our treatment. As I said, we had to deal with anxious people that wanted answers from human beings, and we became the voice of the healthcare system. You are a paramedic, so you are my expert. You're my neighbor. I trust you. And we had to work with our people so they will be able to provide those answers to their families, to their friends, sometimes to their neighbors. What will stay with us? If you see EMS in Asian countries, they wear masks for years. I believe that we will still be wearing masks for a long, long time to stay every time we see a patient. We will have to prepare for our next time, issues around PPE stockpiles, disinfection material stockpiles, sometimes about electronic stockpiles when you don't have international flights became important. International cooperation was extremely, extremely important for us. We learned a lot from the experience of our friends in SAMUR-Protección Civil Madrid. They were 2-3 weeks ahead of us, and we could learn a lot from what they were going through, from their professionalism, from their experience, and we tried to share it with others. We showed how being one family that works together, we are way stronger, and we provided a much better response to the communities that count on us. And if you would have asked me 2 years ago if as a paramedic I will be ever involved in a public health emergency, I would have laughed. And we demonstrated that EMTs and paramedics are an important part of a public health emergency. They can take samples. They can vaccinate people. To put a 23 or 25 gauge needle into the deltoid of a healthy person, you don't need a nurse. Nurses are needed at the HMOs. Nurses are needed at the hospitals. They are critical there. So the fact that our Ministry of Health allowed EMTs and paramedics to vaccinate gave the system the capacity to treat 8,000 new cases a day, a peak of more than 1,000 patients hospitalized in hospitals, and at the same time vaccinate the whole population of Israel almost. And you see the important results that this joint effort gave us. We are very proud of that, and we think that this approach is the one that should be considered for the next time. I would thank you very much for your attention and ask you to stay safe, take good care of yourself, yours, and your team. The word on the slide is tikva, hope. And this year, hope comes with the vaccine. So if you have the chance, please get the vaccine. This is what will take us out as it's happening in Israel. And as of tomorrow, masks are no longer needed outdoors for a long time now, and tomorrow it will be neither in closed spaces. So really, we are walking, we hope, out of it. Vaccinate yourself, vaccinate your family and your friends. Stay safe. Thank you very, very much.
Okay, I have no conflict of interest. So, the context is we have an heterogeneous surge of ICU capabilities between regions. We have some dedicated ICU with COVID patients, but also new ICU outside of the world. It was recovery rooms, medical and surgical wards, cardiac care unit, neurovascular care unit, operating rooms. And we also have a permanent influx of COVID patients in emergency department. We have a statistical modeling of the surge of different services, and we have a forecasting of capacity exceedance date. On the other hand, we have an availability of ICU beds in other regions of France because of the heterogeneous kinetics of the epidemics. So the objective was the release of ICU beds in a saturated region. We organized a transfer of significant number of patients, and the objective was to transfer numerous patients in one single operation. Finally, the transfer of 24 patients by TG, the capacity of an ICU of a city of 300,000 inhabitants. So we could free many beds in one operation. The transfer was possible because some regions were less impacted than others, and we have the projective model which modelizes the saturation. And we can see, for example, a saturation in Grand Est area in France, but not in Britain. You see Bretagne here. You can see on the orange curve the availability of a bed. We are under the saturation line, and also for Occitanie. So this area in France were capable to have many patients.
Benoît, pardon.
Oui.
Vous avez passé les slides.
It's okay? Okay. So the concept of the medicalized high-speed train was first introduced in during the First World War with a sanitary train. Recently, in 2019, we organized a damage control exercise modelizing a terrorist attack in a region in France. The goal was to help regions which was saturated because of many victims, and there was a saturation of ICU and surgical capacities. So we organized extra-zonal reinforcement by mobile intensive care unit and medical surgical teams. The goal was to transfer stabilized absolute emergency patient to another region, and this was the proof of concept which was organized during a university disaster medicine drill, TGV Chardon. So you can see the slide on the picture. It was victims in the railway station in Metz in France, the loading of patients on the TGV, and the organization of care in the TGV here in the car, and the control room, the control car during the transport of the patient. So for COVID, the transfer of COVID patient was the logical continuation of the Chardon exercise. We organized 10 transfers between March and April 2020. The origin of patient was Grand Est on Île-de-France region, so about around Paris. The destination of patient was Bretagne, Centre-Loire, and Aquitaine regions. It was 1 or 2 trains on the same day. The logistic was very complex. It was organized with the French railway company SNCF. We have human and material resources, and we need a synchronization between all actors. The procedure was gradually optimized, and we have no noticeable incident during the 10 transfer, but we have some minor difficulties due to the deviation from the initial procedure. So the transfer was prepared on D-1 day before. So we have a high-speed train TGV, which was provided by the SNCF. It is an 8-car train set with 6 cars which were transformed.
Benoît, pardon.
Yes.
put the presentation in the way presentation of the PowerPoint, because if not, it's not possible to pass the slide. Do you understand? Yeah.
Sorry?
You have put the presentation in the normal way, not in the way of presentation, down of the PowerPoint. Yeah.
Ah,
Yes.
yes.
For this reason, you don't pass the slide.
Like this?
Yes. In this moment, we have seen the slide of the old train, but it's not the slide of this moment. Pass the slide, please.
It is okay, no? Yes.
Yes, but in the presentation way,
Yes. It is okay. It is okay, no?
Screen mode. The full screen.
Yes. You see only the slide, not the presentator mode.
if you want, come back to put the presentation. Perhaps the program. Si la presentación la quiero compartir, estamos muertos.
Share the screen.
The problem is that you are in the same slide.
No. I say, and I think it's a. I go on. Enrico, je continue.
In this moment, you are seeing the slide of the Austerlitz station.
Yes.
Yes, yes. Pass the slides during your dialogue. Yes.
Yes, I go on. So. Enrico, je continue?
Yes, continue.
Yes, okay. Sorry. So each TGV is organized in 8-car train set. 6 cars were transformed in intensive care unit. 1 was a hardware reserve car, and we have 1 coordination car. It was double floor train. The lower floor was organized for ICU patient, and the upper floor was dedicated to material and circulation between cars. It was a double train set. The first train was opener because we have less traffic and we have to be sure that there was no obstacle for the train. And the first train also contained many power generators because TGV is electric. And the departure station was Paris-Austerlitz. Okay. So next slide. So we have a pre-routing of medical teams on equipment. The pre-hospital MICU and ICU teams came from the destination hospital, and they have a pre-hospital MICU and IQ equipment, monitor, respirator, vacuum cleaner, pumps, vacuum mattress, drug and consumable, and also protective equipment. The oxygen was provided by the French Ministry of Health, and the logical assistance was provided by SAMUR of Paris. Finally, we have a transformation of each car in a collective MICU and for 4 severe ICU patients for 1 car. The selection of the transferable patient was organized 1 or 2 days before the transfer. In ICU, which were saturated, we take 4 patients from 1 service or 1 hospital with an equal distribution between university and community hospital. The selection of the patient was validated by a regional coordination center. We have rigid criteria for the transfer of the patient. The patient should be hospitalized more than 2 days after ICU admission. They were not expectable to be withdrawal of ventilation in the short term. Oxygen inspired fraction was less than 60% and PEEP was less than 14 millimeters. The patient were possible to norepinephrine but less than 0.15 microgram per kilogram per minute. They were weaned from ventral decubitus on extrarenal epuration, and the weight should be less than 100 kilogram. Finally, because of the risk of last time cancellation, we have to take 1 or 2 joker patients from each ICU. So the care of the patient from the original ICU was organized by the teams of the destination service or hospital. The team were standardized, 1 or 2 ICU or emergency physician with 4 nurse or anesthetic nurse. We organized convoy of 4 medicalized ambulance, MICU or medicalized rescue vehicle, or alternatively, we organized a bus with a SAMUR-92 who take 6 patients in the same time. And we have 1 local facilitator for the convoy with material in reinforcement if necessary. The chronology of the transfer, the departure of the team from the railway station was 4 to 5 hours before the train departure. The care in ICU was 1 and a half hour. The return of the convoy to the Austerlitz railway station was organized, and after we have a local coordination for patient loading.
Benoit, you must pass the slides because we have yet in the slide of Austerlitz.
Ah. Yes, it's a good slide. Yes. So the installation of the patient in TGV was very complex. We need help from the associative first aid workers for stretchering and accompanying. They were coming in the train for accompanying during the transfer in TGV to help for unloading. Sorry, I have to change like this. The transfer was organized and with 4 ICU beds for each car in the TGV. The lower floor was dedicated as a contaminated area, 1 or 2 doctors and 4 nurses. The staff was equipped with protective equipment, and we have 1 logistician in uncontaminated area. The upper floor was an uncontaminated area. It was a living area with equipment for reinforcement, and it was a circulation area between cars. We also organized a command unit in the restaurant car, 1 medical coordinator, and we organized the preparation for unloading, 1 or 2 patients by car if there was an intermediate destination, and we organized a change of patient destination if necessary in case of instability of logistical constraint. Okay. So in case of intermediate destination, we have to unload 1 or 2 patients from each car. This was anticipated during installation, and the patients to be firstly unloaded were located near exits. All the patients have the equipment of the destination services. There was possible change of the patient medical team during transfer by TGV and after transfer by ambulance. The loading time was 15 to 20 minutes for 1 patient for 1 car, but since we organized the unloading of 6 cars simultaneously, we could unload 6 patients in 20 minutes. At the final destination, we have to unload all the patient or all the Western patient. The ambulance of local team were ready. The objective was a single rotation of ambulance from the railway station until hospital, and perhaps sometimes we have to reorganize the destination because some patients were more severe and they have to change of final ICU destination. For the return of the teams to Paris, it was either in the same high-speed train TGV going back to Paris, or sometimes we went back to Paris by a special military chartered flight. You can see here, provided by the French Army. Sorry. In summary, for this high-speed train transfer, we have 10 interregional transfer between March and April. The total was 200 patients who have been transferred, 10 to 24 for one TGV. It was a very complex human and material logistic, on 1 or 3 days for preparation. It was apparently easy, but we need to be rigorous, and it was a quickly well-established organization. However, we have the reoccurrence of delays due to deviation from the initial procedure. The most important point is that we had no aggravation or major complication, neither no deaths during transfer of this severe patient. It was a major success, but above all, it was a solution that avoided overwhelming of ICU capacity in some French region who were very close to saturation. And you have on this slide the summary of the train transfer. In Maron, you have all the transfers. The Chardon, you see, is Chardon 1 for 20 patients. On the 3 days before, where the preparedness of the transfer. You see Chardon 2 and 3, 4, 5. Sometimes we have 2 TGV on the same day. And you can see in the blue, it's the unit transfer by helicopter or flight, a special dedicated flight for transfer, which have been organized parallelly to the transfer of by TGV. Totally, we transferred 600 patients from different regions of France during this period. And we have not a lot of paper of publication, but this publication in Annals of Intensive Care in March 21, and we have the comparison of patients. 68 patients were transferred versus 65 not transferred, and there is no difference in mortality in ICU or hospital mortality of diverse parameters. The only different parameters were longer mechanical ventilation duration and duration of neuromuscular blocking agent use for the transferred patient. Finally, this was a very useful new technique to transfer patient and to free a bed in a saturated region of France. Thank you for your attention, and sorry for the technical problems. Okay, so I have finished.
Thank you very much, Benoit. After the end of the presentation, we will arrive to the question time.
Thank you for the invitation. My name is Fredrik Lippert. I'm from EMS in Copenhagen. You will get my affiliations here, and are welcome to get in contact if you need further information or if I can answer any questions you might have afterwards. The European EMS Leadership Network is an organization within major EMS organizations in Europe. It consists of, from the left, the Netherlands, from Ireland, from Scotland, from Berlin, from Paris, from Helsinki, from UK, and from Madrid, as you can see. And the last person is me from Copenhagen. And we send out a YouTube video with greetings to all of you EMS personnel as frontline for what you have been doing last year. Please see that on YouTube and be honored by that we greet you. One of the persons in the European EMS leadership, I'm proud to say, is Vídeo from Madrid. Thank you for that, Vídeo. The next 20 minutes, I'm going to talk short about EMS in Copenhagen. What's the background? How did we manage COVID-19 here in Denmark? And what is the role of EMS in Denmark during the pandemic? And also tell about the successes we have had. And finally, something about future impact on EMS, what we have experienced. But let me first go back to Copenhagen, Euro 2020, the football match last Saturday. Sad tragedy. One of the players had a cardiac arrest in front of all of you watching football, and we are very proud of the team there, how they handle that, and how they managed to get him resuscitated. And even for such a case, did we win or did we lose? Denmark lost the Euro 2020 match to Finland. However, we and CPR did win the match about life and death. And even in such a case, you get questions about COVID. You get questions about vaccination, and you got all those theory that he might have had this cardiac arrest due to vaccination. And even in that case, it is part of the social media discussion. And I'll leave it there because there's nothing about it. It was a cardiac arrest in a football match. But this just tells us how much this is in people's lives today, even 1 year after it started. Back to Copenhagen, wonderful Copenhagen, summertime, and to EMS in Copenhagen. We are part of the university and a healthcare institution. EMS is made by people. People make EMS. So we have the dispatch center, we have ambulance services, and we have a lot of different tasks there. Copenhagen is known for the traditional ambulance services, the dispatch centers, which is integrated. We use a lot of data, we do research, and we have innovation, including artificial intelligence. And what is most important is actually to implement the new things that we find and the new things that we consider important for our patients. To understand how we manage COVID, I just want to tell you something about the healthcare system in Denmark. We have a population of nearly 6 million people. It's a public healthcare system. It's financed through taxes, and we have equal and free access for citizens. Emergency medical services is an integrated part of the public healthcare system in Denmark. It's not like that everywhere, but it is in Denmark. And I just want to say that we work together with 29 municipalities, 4 police regions, and 7 fire and rescue services, besides the hospitals, which we are part of. Our task in the healthcare region is to take and make priorities for healthcare-related emergency calls, 112 calls in Europe. We also have a medical helpline 1813 for healthcare advice and admission to emergency departments. So if you want to go to an emergency department, you have to call this number before, and we will book a time for you in the emergency department. We also have a dispatch center doing all the pre-hospital resources, allocating priorities, and we are responsible for medical preparedness and contingency planning, meaning also COVID. And when COVID came, we had the task of doing COVID testing in our community, and also now COVID vaccination. Just few figures on call volume: 130,000 calls in Copenhagen to 112, 1 million calls to the medical helpline, 300,000 ambulance missions, and 500,000 scheduled patient transport. So we are busy. I want to go back to COVID and New Year 2019. So when you celebrated your New Year 1920, you were considering what's going to change in 2020. And none of us could predict that COVID would change our life. It changed our life, and it changed the lives of EMS 3 months later. So we couldn't predict that future. And if you want to see more about this, you can just go to the movie Contagion, movie 9 years old, and it's actually predict a case where a deadly virus was spread in the community and the impact it had on us as human beings and our behavior. But none of us predicted that in the new year when we celebrated it. So before March 2020, we were busy in EMS, and after March 2020, we were even more busy in EMS because new tasks appeared and new procedures came to us. So how do we manage that COVID-19 pandemic in Denmark? Well, first of all, I would like to say we never got close to the limit of our capacity in the healthcare system. Italy did, Spain did, France did, and other countries absolutely did, but we did not in Denmark. We had an early lockdown of the country, very early in the spring. We had centralized decisions and recommendations from the National Board of Health on what to do and when to do it in order to prevent the COVID in spreading in our community. And the Danish citizens actually trust the authorities and follow the recommendation given by the National Board of Health. We started testing early, and we have tested more than any other countries in the world. And we have had a very effective vaccination program, meaning that we are currently 50% of the population are fully vaccinated. And another important thing for us is that we are a highly digitalized nation. We have information as citizens. We were able to provide that information to citizens for testing, for booking time, for testing, to organize that electronically, also to get a corona pass electronically, and made it easier for people to get their information timely and right. Otherwise, it was the same as in the rest of Europe. We went to work, and much of the country locked down. So we said, stay home, please stay home for us. We are here for you. And that is what we did in the ambulance services, and that is what we did in the dispatch center. I'll just come back to some data from Denmark on how we manage COVID. These are data from Spain, from the WHO homepage. And as you can see, you had different peaks in the COVID throughout the year, actually 3 peaks or more in that, and you ended up with 80,000 deaths in Spain for a population of nearly 50 million people. Compared to Denmark, we had only 2,500 deaths. And we have 6 million people. So if we had the same number of deaths that you have in Spain, we would have 12,000 deaths. We didn't, we just had 2,500. And we only had one peak in all that period, and a smaller one later. That was due to the way it was handled by the governments, the central government.
We had new tasks and responsibilities for emergency medical services. For instance, new daily procedures on wearing personal protective equipment. This was to protect our staff from COVID and our patients. And in the beginning, being very worried about having sufficient PPE, but we had sufficient protective equipment. We also had new procedures for dispatch and referral of patients. Our dispatcher had to find out if this might be a COVID case and not during that emergency call. Also had to consider if the patient could be treated otherwise than going with an ambulance. And if going to the hospitals, we had new procedures on delivering patients to, in the beginning, COVID dedicated hospitals, and later to all hospitals, but specific areas within for COVID patients in the emergency department. All patients had to call our dispatch center for access to emergency department, and this was a huge benefit for us because then we could actually control the influx and flow of patient in hospital in our dispatch center. So they couldn't just turn up in an emergency department being a potential COVID patients. They had to call us beforehand. Patients with symptoms could not be seen by general practitioners. This was made as a central recommendation. So we had to go out and see patients that general practitioners normally would see during daytime. We had more complicated procedures for hospitalization, meaning that transfer patients, making aware that this was not a potential COVID patients, and also making sure that we protected the staff in hospital. We had also more complicated procedures for hospitalizations in general. Hospital transfer time increased, so we often were queuing up with ambulances in front of the hospital to deliver patients, but that's you also saw in Spain. And then we had new tasks with testing in the municipality and institutions, a huge task going on from the very beginning and until now and still going on. So we are testing more than 100,000 people in Copenhagen daily. We also had new tasks with testing facilities for the community, going out in institutions and for vulnerable patients. And finally, of course, this year, new task with COVID vaccination, building up centers. In the beginning, these centers for testing and vaccinations were tents, but now it's buildings and it's institutions that is there, and we have a lot of them. So there's short way for citizens in Copenhagen to be tested and to be vaccinated.
And this is the head of the National Board of Health. He also joined us in spreading the message. He's actually a nice guy, but this was part of a movie to make fun about it and to encourage people to follow the recommendations. We did so in the ambulance services, as you can see on this picture. Personal protective equipment was in place, and we handled patients in a different way than we used to do, but it was the same treatment. We also were responsible for reach outs team for testing, for breakouts, and in institutions. So we had a lot of cars going out each morning and continuing all day, testing in institutions to keep the virus from spreading in the community. Testing and vaccination also became part of our lives. We actually have 3,000 additional people just for testing and vaccination in Copenhagen. And we're testing more than 100,000 per day, daily, throughout the year. An important task. Other experience that we have had is treat and release. We use treat and release more often than we did beforehand, meaning we want to help the patient in their home and try to leave them in their home unless it's absolutely necessary to go to the hospitals. So this was part of the strategy. We also used video consultations to make assessments of people without seeing them from the dispatch center and see who we actually want to go to with the ambulance services. We have been discussing staff shortage, but we have had very few COVID positive staff in our EMS compared to the population, despite that they were frontline personnel, but it shows that they used the personal protective equipment right because they didn't get infected. Now they are all vaccinated, of course. Mental fatigue could be expected, but it has been less than to other groups in the society and in healthcare. And EMS resilience proved to be very high in this COVID year. The perception of EMS in the society also changed inside healthcare. A lot of recognition of the task that's being done by you, and also a lot of recognition from outside healthcare on what is EMS and what is the important role of EMS in our country. We looked to new solutions. So, for instance, we had various telephone lines being for support for citizens being in doubt of what to do, when to do it, and get some kind of support for either booking times for testing or vaccination as well. We thought that it would be nice to have a chatbot to help people furthermore, so we decided early to establish a COVID chatbot together with Microsoft. It was developed within 48 hours and up running, and it was very popular. And later we added information about when to be tested, when to be vaccinated, and how to do that. We also made a artificial intelligence COVID project, see if we could detect COVID during the emergency call for potential patients there. Research was part of what we were doing in Copenhagen, and I just want to show you one important publication made from Copenhagen or from Denmark. It is the study, a randomized controlled trial, trying to see if face mask would prevent spreading of virus in the community. 60,000 people were enrolled in that study, and it didn't, unfortunately, it didn't reduce the infection rate among those who wear the face mask more than 50%. It was effective, but it was not as effective as we thought so. But this study was also limited because we had already other regulation in place, meaning low infections rate, social distancing, and that might be one of the effects. But we still continue using masks actually until this week, and from this week it's no more mandatory to use mask when you go to restaurants or doing shopping. So that has changed in that period. And finally, COVID changed the role of EMS. We are frontline personnel. We are part of our community. We are here for our community, no doubt about that. And EMS has shown and proved that it is an agile entity in our community, and we can do much more than we believe and that we thought beforehand, and people also know that now. So in summary, we in Denmark successfully handled the COVID-19 pandemic. EMS had an essential role as frontline staff in control room and in ambulance services. We reached out to the community and we gained respect from our community, our support and agility. We should keep going forward to new roles and new responsibilities. And I think the biggest risk here is to go back to as it was before COVID, when the time is. We should learn from what we have obtained, what we have achieved in that period, and use that and go forward with new procedures and the new responsibility and roles in EMS. Finally, if you want more information, please go to one of these websites, including the European EMS Leadership Network. And I hope to see some of you for the European EMS Congress 2022 in May in Scotland. Thank you very much.
Thank you very much, Freddie. I know that you are connected now. And we pass in this moment to the fourth speaker, is Jim Ward. Jim, are you connected?
Buenos dias, Video. Yes.
Okay, Jim, we can see your screen, so when you want.
Okay. Can you see the presentation?
No. La presentación, vale. Es que me lo
All right.
Yes, Jim.
Okay. Okay, thank you. My name's Jim Ward. I'm the Medical Director of the Scottish Ambulance Service, and I would like to start by thanking your Vídeo for inviting me to speak to you today, and also say how interested I found the previous 3 speakers. Lots of overlap between what I've heard from Chaim Rafalowski in Israel and Freddie Lippert in Copenhagen, and not so much in terms of trains from Benoit, but I'll come on to that. And my dog has started barking. I hope it's not too noisy. First of all, just to say a little bit about Scotland. So we are part of the UK, and our population of 5.5 million is spread across quite a large landmass. Most people live in the densely populated central area. That's where you'll find cities like Glasgow and Edinburgh, and I'm sure a number of people on the call will have visited Scotland. But 40% of our people live in rural areas of Scotland, and we have many populated islands, 94 islands, wholly populated all year round, which poses a significant challenge in terms of delivering emergency care. We have a socialised and integrated health and care system where all care is provided, taxpayer-funded healthcare system, which is free at the point of use. We have no health insurance. Our situation is politically complex at the moment. We left the European Union at the start of 2020, and then things got even worse with the pandemic. So I'll say a little bit more about that. In terms of the Scottish Ambulance Service, sorry, I'm getting an echo. As part of Scottish Ambulance Service, we are the national ambulance service for the country. We employ 6,500 staff, of whom over 1,000 were recruited as part of our COVID response, and I'll say some more about that. We provide all traditional EMS frontline operations. We run 3 ambulance control centres. We have a nationally coordinated aeromedical response, which both provides primary response to situations like major trauma or major incidents, but we also do many retrievals across the country for people who need our help in remote and rural communities. We have a special operations function, which provides a very specialist response where that's needed. We have a patient transport part of our organisation which supports outpatient clinics, and that will undoubtedly be changing as changes in practice with COVID come through. And we have around 1,400 volunteer responders. I was very impressed by the number they have in Israel. 1,400 is a good number for us, but we clearly could do more in that respect. So in terms of updating around our COVID response, I'll say a little bit about preparedness, something about initial response, remobilisation, and then ongoing issues. In early 2020, we were watching the news and with a growing sense of alarm, seeing what was happening in Wuhan in China, and then stories from Italy and Spain, really describing very concerning scenes in terms of healthcare systems coming under huge pressure, and the risk being that our systems may collapse. So some of the things that we did within the Scottish Ambulance Service were we revised what's called our DCR tables. Now these are the ways in which we decide what to dispatch depending on clinical acuity, and these had to be recalibrated quite significantly with the expectation that we would be both overwhelmed by demand and see a significant reduction in our capacity. We set up a series of coordinating structures in terms of national and local cells to make sure that we could coordinate both response, workforce, but also crucially PPE. PPE on a normal day-to-day basis pre-COVID was never an issue, but we knew that this was going to become a significant issue as the whole health and care system required to significantly increase its access to this really important work. We further strengthened our face-fit testing work, and we've now completely changed how we approach personal protection for aerosol generating procedures. I'll say something about that at the end. And we optimised our staff messaging, as many of our staff and others across the country were becoming increasingly concerned about what was going to happen. Of course, it wasn't just the ambulance service that was under pressure. There was a real climate of fear and uncertainty across the whole country. And when we went into lockdown, which there are lots of arguments about the time it took to make those decisions, we closed the economy and all social interaction. We were then clearly in a situation that none of us had ever been in before, and there was significant ongoing concern about ICUs and hospitals being stretched to breaking point. That resulted in hospitals discharging many patients back home and into care homes, and we've seen significant numbers of deaths in our care homes, and there are arguments that the hospital discharges may have triggered some of that infection. That's still under review. People stopped attending our emergency departments. There was a real change in people's behaviour, probably fueled by a perception of two things. One, that the NHS needed to be protected, but secondly, that hospitals were becoming dangerous places to go if they were being full of patients with coronavirus. We stood up new facilities, probably in response to the Chinese claim of building a hospital in 6 days, but in the event, the facilities that we stood up have never been used. Within the ambulance service, we saw huge logistical challenges in terms of sourcing and distributing PPE, and on the background of staff apprehension, this required a lot of clear communication and reassurance, particularly for those staff faced with carrying out resuscitation, and I'll say a little bit more about that. In the initial stages, there were serious limitations in COVID testing. The only patients who were tested for COVID were those being admitted, and that meant that lots of people who we were managing in communities still to this day don't actually know whether they had COVID infection or not. And what we saw were multiple changes in clinical guidance and infection control guidance, and some significant disagreements about guidelines, particularly within the resuscitation community around what constituted aerosol generating procedures. However, in among all of these stress and tensions was the opportunity to do new things, new ways of working to reduce demand, such as increasing remote consultation, new opportunities to manage more people outside of hospitals, and opening up of pathways, care and decision support to allow us to do that. And we've seen all of the above, and I'll say a little bit about that. First of all, around the impact of the pandemic on our cardiac arrest performance. In Scotland, we've had a national strategy to improve survival from cardiac arrest that we launched in 2015. And up to 2019, we'd seen almost a doubling in survival. The chart at the top left of the page shows that our VF-ROSC rates were sitting around a mean of 50% in the year or two leading up to coronavirus. But in March 2020 and through to May 2020, really fell quite sharply, down below 30% at the worst of the stages. But thankfully, they've bounced back to pre-pandemic levels, and we've managed to sustain that. And we did a huge amount of work in terms of translating the practical application of the guidance in the context of the Resuscitation Council in the UK saying chest compressions were an AGP and our government scientists saying they weren't. We tried to really just ignore that dissonance and provide practical, clear advice for our crews about how to protect themselves and do the best for the patients, and let the experts argue about the science. the infographic at the bottom of the page is something that we circulated around all of our stations in May last year and was very well received by our staff. Another initiative that we brought in was remote consultation. This is in addition to our AMPDS consultation, and what we identified were a number of codes that were suitable for advanced practitioners. So our advanced practitioner cohort, who were all very experienced in working in primary care, were all relocated into our ambulance control environment and provided remote consultation either by telephone or video. We have managed now to stabilise at around about 14 to 15% of all treble 9 calls being consulted remotely, and about half of them then do not need an ambulance to respond. So it's been quite a significant impact on our overall business. And this is something that we're looking to embed as we remobilise and recover from the pandemic. A couple of charts around the impact on staff. I'd mentioned earlier the fear and uncertainty generated by the coronavirus, and these two charts show a couple of outlines about the impact. The top left one is around COVID related absences, and you see them reflecting wave 1 and wave 2. Our second wave took us over New Year. The second chart shows an emerging pattern of people who are unable to attend work because of what they're calling long COVID, and I think there's lots of work being done to understand that. But both of these stats really reinforce the vital importance of looking after our staff and all of our personnel, as Jaime said. So we've launched a new wellbeing strategy, and these are a couple of our infographics from there. The idea being that if we create and sustain a healthy culture and environment, then people can thrive in that environment. And this is broken down. There are dozens of specific initiatives that staff can access either in work time or in their own time to promote their well-being. Some new work that we took on, similar to other systems. In the initial period, the coronavirus testing was done by the military, and in Scotland that's now been taken over completely by the Scottish Ambulance Service. To do this, we've had to recruit over another 1,000 staff. The way that this works for us is it falls into our established expertise around response and logistics. So we're able to rapidly deploy testing teams across the country at short notice and often in remote locations. And this is very much in response to where we're seeing outbreaks as we try and stave off a third wave. Similar to what you heard from Israel and Denmark, the UK has had a very successful vaccination programme. Within the Scottish Ambulance Service, we've now vaccinated to 2 doses, something like 95% of our staff. Those that haven't been vaccinated, if they're willing to be vaccinated, will get the opportunity. They've usually not had it because they've not been at work. But more recently, we've started to support the public coronavirus vaccination scheme. And this is really important because one of the things that we know is that COVID mortality is worse in certain groups within the community, people living in areas of high socioeconomic deprivation and people with some other characteristics. And what we can do is we can take the vaccine, take the teams, either in small areas of deployment, or we have a couple of vaccine buses that we use now, into remote communities, but also more importantly now into hard to reach and excluded groups such as homeless people, gypsy travellers, etc. And very much targeted at the hotspots and where we need to be intervening. Freddie mentioned a little bit about the system in Denmark and in terms of phoning before you attend the emergency department. And pre-pandemic, a number of us had visited Freddie's system in Denmark to learn more about that. And as we've remobilised through COVID, this has been a big initiative within the Scottish healthcare system. So we've now got a national programme about redesigning urgent care, aimed at improving flow through emergency departments, offering alternatives to emergency departments and introducing scheduled appointments, including opening up other bits of the system for opportunities for remote and community care. And this is a major work stream. And as we move to phase 2 of this, the Scottish Ambulance Service has got a dedicated work programme. So this is one of these areas where learning from across the system, which is what days like this is all about, can actually translate through to opportunities. And this is the logo. You see this here first. This is about to be launched as a national communication programme in the next few weeks. Ongoing issues. We are still in a difficult place. Most of our country is still in fairly significant degrees of lockdown. We still have masks everywhere indoors. We still have significant bits of the system that are shut down, and that brings with it ongoing fatigue and frustration. We have 2 political leaders in Scotland. One is Mr Johnson, who's our Prime Minister in the UK, and the other is Nicola Sturgeon, who's our First Minister in Scotland. Their politics could not be more different, but what I would say is that for most of the pandemic, they've managed to put some of those differences aside and try and focus on what's important for the people. As we move out of the pandemic, no doubt normal politics will return as normal. There's huge uncertainty around the medium to long-term economic impact of the changes we've had to put in, and that's a big concern for public sector organisations like the ambulance service in terms of future financing and the like. And what we are seeing now across the NHS in terms of emergency care is that demand is now back to pre-pandemic levels, but the constraints of working in COVID remain, and that means that there's long waits at hospitals to hand over patients. Generally, the population finds it difficult to access primary care. There's high rates of sickness within health and social care staff, and of course all the issues around pre-COVID in terms of a ageing population remain. So it's been challenging, and it's going to remain challenging. However, to finish with a note of hope and optimism, this little coin is something that the Scottish Ambulance Service distributed to all of our staff with a personal note from our Chairman and Chief Executive, really just thanking people for all their incredible efforts through the COVID pandemic, and encouraging us all to work together for the challenge that we face in the future. So thank you very much for the opportunity to speak to you today, and thank you for your courtesy in listening to me. Thank you.
Thank you very much all for your presentation. Thank you, Jim. Thank you very much all for your presentation. Thank you, Jim. Excellent conference. Thank you. Thank you all. And now we're going to the question time. ¿Tenemos alguna pregunta desde aquí? This is a question for all, no? If you have to choose an answer, what were for each one the main difficulty during the pandemic, and also the most unusual action that your service had to carry out? Do you understand? Yes, ma'am. No? Do you hear me?
Yes.
Yes. Do you hear the question?
Oh, it was a bit difficult to hear with the mask on. Sorry.
Yes. Please, Vídeo, could you remove the mask if you are alone? in your room.
Yes. The question is, if you had an aspect, only one aspect, what were for each one the main difficulty during the pandemic, and also the most unusual action that you
Survey that had to carry out. For example, first chain is okay?
Yeah. I'm just trying to unmute myself. Can you hear me, Vídeo? I cannot unmute myself.
Hi,
do you want to?
last word, please.
Servicio.
Sí.
El sonido está bloqueado y no puedo ponerme en unmute. El micrófono lo tengo bloqueado del lado de ustedes. Estoy muted y no puedo hacer el mute.
¿No puedes hablar a través de Teams?
No, porque el micrófono está bloqueado.
Tim, perdona, ¿me escuchas? Tim,
Sí.
te escucho perfectamente en sala y en...
¿Ahora me escuchas?
Sí,
Porque
tenías
aparezco bloqueado.
bloqueado.
Entonces,
Sí, si cuelgas
¿me
el
escuchan
teléfono,
ahora? Por favor, si me puedes indicar si me escuchan, no por el teléfono, sino por el Teams.
te escuchamos por Teams perfectamente, Tim.
Pero en inglés, para que te oigan el resto de
Okay. So I will switch to English, and sorry about the technical issue. The most challenging thing that we had to do during the pandemic was dealing with the needs of our personnel. Normally, we are used to the idea that they come to shifts and they go. And suddenly we had all those issues around people that are afraid to come back to their homes because they're young and they live with their elderly parents, or they have small children at home, and we had to find solutions. So suddenly we had to create a whole system for dealing with the needs of personnel, which is not normally in place. And I think that was our greatest challenge. Setting up a whole system to deal with testing was something that we are not used to. And it's not, it seems like the small part of the thing is, let's take the test. And EMS personnel are used to working in PPE. It's our daily job. But suddenly you had to create a whole system for tracking the tests and delivering them to the laboratory. And of course, tests that are lost, tests that did not meet the required standards. It was a whole logistics operation that we had to create in a very, very short period of time. And I would say that was our greatest challenge. And again, thank you for the invitation.
Vídeo, can I comment, please?
Yes, for example, Freddy.
Yeah, thank you. I would say the biggest challenge we had was also, like you mentioned, just setting up testing. We had 2 days to do that, setting up testings in all of Denmark and coordinate that in tents initially and later in buildings, and also later setting up vaccination centers as well. A huge logistic task, a lot of people involved in that, and it worked fine. And so it was a success, but it was a huge challenge and a lot of effort put into that. And if I could comment on the staff thing, I would just say we had, it wasn't a surprise, but we had a very loyal staff. They trusted us, they trusted the authority, and what we saw, despite that we initially had lack of personal protective equipment to the degree we wanted, but we have seen that our staff in the ambulance services and in the dispatch centers had less infection compared to normal citizens. And that was because they used the procedures we had. That was because they protected themselves and protected their patients. So that was a very good benefit that we saw. Serious guys and girls, unselfish in what they were doing, and they showed the agility and the strength of EMS in Denmark as frontline personnel. Thank you.
May I speak? Yes. As far as the major challenge for the per-hospital emergency department for the dispatch center was the increase in the number of calls every day. We have a 5-fold increase in our dispatch center, and this was much more higher than our capacity, technical capacity, and personal capacity. We have to increase the personnel, and much difficult it was to increase the number of telephonic commutators. It was done in a few days, but for the standard activity of SAMUR in Paris is about 2,000 calls every day, and we increased to 12,000 calls on one day, and we have some delays for response. And another challenge generally in France was to follow the multiple change on requirement of health authority, because it changed from one day to another, from 1 week to another, many change from guidelines coming from authorities.
Jean?
Yes, thank you, Vídeo. It's a good question, but I'm not sure that it has a simple answer, because the significant issues changed as we have journeyed through the pandemic. So at the start, I would agree with Benoit, multiple changes in guidance, understanding as we've understood more about the virus, etc., accessing PPE. The thing with this particular situation, it seems to be that just as you get on top of one part of it, something changes and then you have to respond. So we're in the UK and in Scotland, we've got major issues with the Delta variant, which was previously called the Indian variant. But we've had, Hein said a bit about the English variant or the British variant, so it just seems as if things change. We've not come close to what I'm hearing from Israel and Denmark around relaxing of the kind of societal side of things, and I think that and the relentlessness of the work is one of the things that puts the pressure on our staff, not just on EMS and ambulance staff, but on health and social care staff generally. That's why such a big focus then is on support and well-being.
Thank you for your answer. Ferhaze, I want to ask you one not easy question, no? It's for all also, no? In the first moment of the pandemic, did you detect delays in the care of patients with time-dependent pathologies, especially cardiac arrest, due to protection measures? I know that Jean has asked about it, no? But what is your idea about that? If you want change, you are the first. Shane?
Yes, we have to recognize that during the first, I would say, 2 months, every cardiac arrest patient or every respiratory arrest was a suspected COVID patient. And back then, suspected COVID patient meant full PPE, N95, a visor, and 2 pairs of gloves. So by default, there was a delay. I have to say that at the beginning, we even had a procedure where you would not approach the patient. The first 2 months, the idea was you arrive to, and that's with a pre-screening by the call takers. But since we did not trust the pre-screening over the phone, the idea was that you would go to every call in every apartment with your PPE bag on top of your normal equipment. You would stand 4 meters for the patient, ask the patient to put on a surgical mask. You are with a surgical mask, and you start the interview. And if you have the suspicion that the patient is a COVID patient, you would say, okay, please hold on. We are donning on PPE, and then only then we will start caring for you. And the only exception to that was CPR, where you would send one person with an N95, put on the patient an N95, and start chest compressions only until you have team members that are fully protected. So yes, there were delays in the way we responded to CPR situations, and I would say even today, because in Israel still, with all the relaxation that we have around us, if you have a patient with a sudden onset of respiratory syndrome that is not explained by underlying causes, you would don on a minimum PPE, which is your garment, your N95, your goggles, and of course the gloves before you start treating the patient. So we are still with that level of suspicion, and I would say that in my mind, our challenge in the weeks and months to come would be to find the golden path between our safety and treating time-dependent pathologies fast. We are not there yet. We are not there yet because we don't know enough about the virus, about transmission of the virus, especially with new viruses, and with the idea that in Israel we are very worried about variants and how contagious they are, and how safe we are with vaccines, because in Israel, 40% of the new confirmed cases are vaccinated people that, of course, have a minor disease, but they are still vaccinated. So we still have a way of learning ahead of us. Thank you.
Freddy?
Yeah, I can continue. It's much the same we experienced in Denmark and we practiced in Denmark as you did in Israel. I just want to say one thing that we did and maybe you also did that, but what we emphasized was you take any emergency calls like you always did. And when you have assessed the priority and the need for a response to that, then you asked about COVID, infectious diseases, status and things like that, so that we actually got that information beforehand and we sent it afterwards to the ambulance staff, so saying there's no symptoms, there's no risk, there's no whatever, what we know and for now. So they were well informed before they arrived. Then they did like you did, like you tell, sent one person in, assess the scene, and assess scene safety was then had a different meaning than it used to be, but that is what we did. Another thing we didn't change our practice in CPR for our staff, but what we discussed a lot was our civilian first responder program, We have 120,000 civilian first responder for cardiac arrest in Denmark in an alert system like Good Sam and Pulse Point. It's a hard runner program. 120,000 people, lay persons, going into patients' homes, not only public places. And what we had a huge discussion about, should we postpone this program, or should we take special measures there, or should we leave it to the individual what they want to do? And we said to people, there is a risk for you to get infected. The risk is small compared to saving a life, but we recommend you to, of course, wear a mask. What ended up for us was nobody declined to as a solution. We didn't have a line. So they actually took this. Thank you.
Yes, Benoit, yes. In
Benoit,
France,
yes.
yes, we have some delays, as presented by Chem and Freddy. We have delay for individual patient because we have to wear protective equipment, and every time because we don't know if a patient is COVID was at the beginning of the pandemic was COVID or not. So it was a systematic for patient, even for trauma patient. And the second delay was for organization of transport, and we have many requests for transportation of patients between hospital, from community hospital, from emergency department to intensive care unit, and we have to organize prioritization between patients, and some patients who have a delay to be cared for in hospital and to be transferred in others.
Jim?
Yeah, thanks for Vídeo. So I showed some data around our ROSC activity, and we certainly saw a fall-off of that over a couple of months at the start. I'm not sure if there was a root cause for that, but certainly PPE, general apprehension, was part of it. Interestingly, our bystander CPR rate has remained between 65 and 70% all the way through. So echo Freddie's point about the community still being prepared to act in that altruistic fashion, which is great to see. At the very start, when there was a significant reduction in patients going to the ED, the question was asked, where are all the heart attacks and strokes? What's happening? We looked at our data, and our calls for chest pain and suspected hyperacute stroke only fell by a very, very small amount. And they're now back to or above pre-pandemic levels. So I think there was definitely an issue around people deciding to self-present to the ED, but it was a bit less for those who would call every week. Thank you.
Close the microphone, Benoit, please.
I think the traffic noise is from Paris, isn't it? In Denmark, we use bikes. Doesn't make that much noise.
Thank you very much, Jim. Benoit, perhaps you must close the window, if it's possible. Yeah. Yes.
Benoit's on mute. It can't be Benoit.
That's it. Well, and in this moment, in this meeting room, we have met all emergency medical service of Spain, perhaps for first time in many months, no? And most of us is a surprised that one of your main activity is the action about the test, no? Because that is not frequent in our service, no? When you began to do the test, and what kind of test? Antibody, antigen? For example, chain.
In Israel, actually, the number of tests has reduced dramatically. At the top of the operation, we had a day where, as a country, for 9.3 million inhabitants, we did more than 200,000 tests, and we had weeks during I would say January, February this year, where we were doing around 180,000, 190,000 tests on a daily basis. That was the peak of our third wave, and that was our main activity. Today, Israel in general is doing around 20,000 tests, most of them for people flying out or in Israel. So the number of tests produced by Magen David Adom is very low. All of them were PCR-RT tests, and it's important to say we were only one part of the testing. We were the samplers. We were not doing the actual lab part, so we set up the facility. Most of them were drive-through tests, some of them for walking people, some of them a large portion, and I'm talking about around 20,000 tests a day in long-term care facilities, because we all remember the first wave where most of the people that were severely ill and died were elderly people. So it started with the long-term care facilities, with home testing for people who are symptomatic, and then grew up to the walk-in and mainly to drive-through testing facilities. And at one point, we did 150,000 tests on one day. And as the numbers in Israel decreased overall, also our activity decreased, and now the numbers for us are very low. And it's a service that Magen David Adom provides together with our primary healthcare system, with the HMOs, running testing facilities for them, because the whole testing operation in Israel has transferred from the Ministry of Health to the HMOs as a primary healthcare activity. And hopefully, as long as the numbers in Israel don't grow up again, it will stay as a primary healthcare activity for the time that we see, and we see this as something that will stay with us for a long time, this COVID testing. Over.
Freddy?
Yeah, from Denmark, I can say testing was initially decided that should be part of public health, should be solved by public health as part of the public health system in Denmark. And when the ministers looked at who's actually capable of doing that in the public health care system, it ended up with EMS. And probably because we are used to change, we show agility in what we're doing. We are mobile. We are experts in logistics and organizations, and we could actually do it. So that was why it was a task that became our task. And we have done that ever since. We started with PCR testing only, and now it's both PCR and antigen testing. At the top, I think it was about 300,000 tests per day. Now it's about 1,000 tests per day, and it's diminishing right now. We are doing more vaccination. People were recommended to get tested twice a week in Denmark. Thank you.
Benoit?
Hello. Yes, in France, the tests were organized by public health authorities, either in emergency department or in private laboratory. And we also have some public building and special place for testing. and it was PCR. And after it was an antigenic test, and now we have the test available in our ambulance, and we perform the test very frequently in case of a suspicion of respiratory disease.
Jim?
Thanks, Avijio. So in our larger cities, we have large static testing facilities that people can self-present to or book a test through the government website. The mobile testing that we took over from the Army is very much reactive to where we're asked to go in relation to outbreaks and responses and whatnot, and that's dictated by Public Health Scotland. The situation we're in at the moment is interesting. Anybody in the UK can ask for a box of lateral flow tests and test themselves. I'm thoughtful about that myself, but that's part of the national, if you like, determination to identify and then respond to outbreaks. Our problem at the moment is that there are concerns that we could be at the start of what for us would be a third wave, where we're seeing increasing cases based on the Delta variant, which again seems to be more communicable than the previous variants. We are not yet seeing significant rises in hospitalizations. However, we are seeing patients who have been vaccinated becoming unwell, and we are seeing some young people, younger than before, in ICU because it's more young people who are becoming infected as they're ones who haven't yet been vaccinated. My reason for saying that is that our requirement for testing is likely to remain in place for quite some considerable time.
¿Alguna pregunta tenéis? Thank you all. We must finish because our translation service is finishing in this moment, no? I want to thank you again for your participation, for your excellent presentation. Many thanks, Shane, Freddy, Jean, and Benoit. Many thanks and a good day. Bye.
Bye. Thank you, Aviju, and
Thank you,
greetings to
Aviju.
Spain.